This is a quick PowerPoint and video to prepare you for teaching patients to use diaphragms and how you can initially fit and prescribe diaphragms for contraception. This is Dr. Schminke. Let's begin. These are the methods we're going to look at in this PowerPoint. The diaphragm is a reusable contraceptive device consisting of a soft dome-shaped cup with a flexible rim. They are available in single size, one size fits most, and multi-size options. These diaphragms in the United States are all made of silicone, but outside the US you may find some latex ones as well. These are designed to be used with spermicide, foam, gel, or cream. Considering the typical use rates of pregnancy that you see listed here, this is a Tier 3 method. In a few minutes, I'll direct you to a video demonstrating insertion, removal, and cleaning of the diaphragm. I have no idea where the physician who made the video got a 5% typical pregnancy rate that he tells you about at the beginning, but the CDC and I stand by the numbers on this slide. The single-size contraceptive diaphragm is known as Kaya, that's the brand, and it's a reusable silicone device that measures 75 millimeters long and 67 millimeters wide. Theoretically, it doesn't require a pelvic exam for fitting, but only 94% of patients can correctly insert and position it after instruction by a clinician in a fairly large study. So I'm a big fan of actually making sure the patient's comfortable placing this and that it's placed correctly. A correctly placed Kaya diaphragm has the anterior rim positioned just above the posterior surface of the symphysis pubis, and the back rim is set deep in the posterior cul-de-sac, thereby covering the entire cervix. It should be pressing against the lateral vaginal walls, and the dome should be with the hollowed side facing the cervix. Now, when you're fitting the multi-size, you'll use a kit like the one pictured on the bottom right. You'll put the patient in lithotomy position on an exam table, and you will choose an appropriate size, and we'll talk a little more about that in the notes section of the next slide, how you do that specifically. But it should also be pressing against the lateral vaginal walls, and the dome should be in the correct orientation, and it should be fitting behind the pubic bone, as I described for the single use, covering the cervix. It should not be dislodged when you ask the patient to perform a Valsalva maneuver or cough. If the diaphragm is dislodged, you need to go to the next larger size and see if that stays in place. We do not fit diaphragms in people who are less than 6 weeks postpartum or less than 2 weeks following a second trimester abortion because their pelvic floor muscles have not sort of settled back into place yet, and they're much more likely to have their to not be appropriately sized when we do the fitting. The phrase diaphragm fitting on this slide is a video link to that great video I was just telling you about, made in the early 2000s. But you can see the notes below for the description of how to actually fit a multi-size diaphragm. You're going to be inserting your index finger or both your index finger and the middle finger into the vagina. Choose according to how big your fingers are. If you have small fingers, use 2. If you have big, chunky fingers, only use 1, please. You want this far enough in so that the tip of your longest inserted finger is at the posterior vaginal fornix. Using the thumb of the same hand, the distance at the base of the finger that corresponds to the posterior surface of the symphysis is marked, and the hand is removed from the vagina, and the distance from the tip of the finger that was in the vaginal fornix to the point marked by the thumb is what you measure. If that distance is 70 millimeters, you're going to choose a 70 millimeter diaphragm to test in the patient. Because so many people are in that 70 millimeter size range, you could alternatively just put a 70 millimeter in to begin with and figure out, is it too big or too small, and then go up or down as you think appropriate. Here's a list of instructions to give your patients on correctly using the diaphragm. I'm not going to read them. You can read this just as well as I can. I am going to talk to you about Phexxi, Phexxi, which is an alternative to naloxone spermicide. This Phexxi is a combination of lactic acid and citric acid potassium bitartrate, and it was approved for contraceptive use in 2020. It doesn't contain any hormones, and because of it, it just seems like a less abrasive kind of thing to be putting in your vagina than a lot of other products that have been on the market before. And this maintains a lower vaginal pH of 3.5 to 4.5, even in the presence of alkaline semen. And it adheres to the vagina, to the vaginal mucosa for up to 10 hours. And so that means it can interfere with a contraceptive ring. If you've got a Nuva ring, you don't want to use that. But the product does require a prescription, so you may have patients asking you about it. And it's supplied in single-dose pre-filled vaginal applicators with 5 grams of gel in each. And you need to insert it no more than an hour before you actually have intercourse, or repeat the dose and repeat it with every sexual act. Diaphragms are cared for the same way we care for pessaries. We wash them with mild soap and warm water and air dry. We store them in a clean, dry container. Of course, you're not usually storing the pessary, but you're putting it back in. But this can be stored in a clean, dry container. They should not powder it. They should not use any other product on it. They should not use petroleum jelly or other oil-based lubricants while they're using a diaphragm, because it will deteriorate the silicone. This is a single user device, so you shouldn't share it with your sister or your roommate. And typically we don't have people using this during their menstrual cycle. In part, again, it's because knowing that it needs to be in there for 6 hours and that it's going to be collecting blood, there's the concern about toxic shock syndrome. These are the 3 complications we see with diaphragm use. Urinary tract infections, we think, may be more likely to occur in women using diaphragms because of the changes in the vaginal flora from the use of spermicides, but we're not really sure. If you've got, you should always check for a good fit of the diaphragm in a patient who's experiencing repeat UTIs. And if it is a good fit, you can consider, if she's really completely set on using a diaphragm, consider antimicrobial prophylaxis. But in most of these patients, the right thing to do is to choose a different method. Toxic shock syndrome with a staphylococcal infection, I've got a little more information about this in the notes here from Up to Date, but it is definitely associated with diaphragm use, as it is with other barrier methods that stay in place in the vagina. And finally, the thing that you're probably going to see most often is people complaining of vaginal irritation. That could be from a reaction from the spermicide, or it could be a friction reaction from the diaphragm. And you might find that you need to refit the diaphragm to deal with that issue. Although I am not going to go into detail about condom use here, I am going to briefly describe 3 other barrier methods of contraception. I think I mentioned earlier cervical caps. The picture in the bottom right is of the 3 sizes of fem cap, or cervical caps, that are available in the United States. These are reusable silicone cups that hold spermicide only about a teaspoon instead of a tablespoon, but it holds it snugly right up against the cervix to immobilize sperm and prevent them from getting up into the upper reproductive tract. the device has to be used with spermicide, and the typical yearly pregnancy rates are in the 13 to 16% range for patients who've never had a baby, and they're over 32 or as high as 32% for patients who've given birth. So these are definitely tier 3 methods. The 3 sizes are small, which is 22 millimeters for people who've never been pregnant. The medium cup is about 26 millimeters, and that's for somebody who's had an abortion or a cesarean delivery without labor. And finally, the large size is a 30 millimeter size for patients who've had a full-term vaginal delivery. The spermicides here they can be inserted as foam, as gel, as these little strips of film or suppositories, and they are going to stop sperm from moving. If they're used alone, it is typical pregnancy rate of around 30%. So you can understand why it is when you've got such high typical use pregnancy rates, why we recommend you use spermicide with condom or diaphragm. And really, I'm not sure what, well, I should say that the cervical cap rates I was just quoting you, that those are with spermicide inside. So, this is still better than not using a contraceptive if you use spermicide alone, but it's a much higher pregnancy rate than we see with most other forms of contraception. It's important to note that naloxone 9 does not protect against STIs, and it may actually increase the risk of acquiring HIV. I'm not sure why that is, but we need to do more study on that. And and as I said, I don't have good data out on the lactic acid, citric acid spermicide that's on the market now, so I can't speak to that. Spermicidal contraceptive sponges, known as or marketed as Today, which I've got shown here on top in the package, and then each side of the sponge. These are single-use thick foam discs that contain 1,000 milligrams of naloxone 9, and they have this loop attached to remove. The cervical caps have a loop also to help you get them out. And the typical yearly pregnancy rates are in 12% range for people who've never given birth and 24% for people who have given birth. So again, a solid tier 3 method. I decided that this wouldn't be complete if I didn't address condoms, both external, or also known as male condoms, and internal condoms, also known as female condoms. The external condoms are devices that can be made of a variety of material, lambskin, latex, synthetic materials. Most marketed, probably 80% or more in the United States, are made of latex. The synthetic materials are intriguing because they have longer shelf lives, and they're compatible with both oil and water-based lubricants. But it isn't so well established how well these protect against sexually transmitted infections. So that's just a little caveat if you're counseling people who need STI protection as well. Typical use pregnancy rates for external condoms alone are 12 to 13% without spermicide. But if you use an applicator full of spermicide, then that, along with the external condom, then the effectiveness increases to just 2.5 pregnancies per year in typical use. The internal condoms are something that are a lot less familiar to most people. These are consisting of one ring that is contained within the closed end of the sheath and serves as the insertion mechanism for getting in, much like you'd put in a diaphragm. And it's like an internal anchor that sits against the cervix. The other ring forms the exterior open edge of the device, and it remains outside the vagina after you've inserted it. The most common kind in the United States now is FC2, standing for female condom 2, which is made of nitrile, and it is associated with a typical use rate of 21% pregnancies in the first year. So that's a number without spermicide, and I'm not really familiar with any studies that looked at with spermicide. The cost of these the cost of these internal condoms is about 5 to 6 times higher than the cost of an external condom or traditional male condom. They're usually about $6 a piece. However, you can sometimes get them for free or at a greatly reduced cost at family planning clinics. So you should see what you have available and what's available in your community. Unlike the diaphragm, sponge, and cervical cap, this internal condom can be removed immediately after intercourse. And an advantage that some people describe is that that external ring can provide some clitoral stimulation during intercourse, which some people find pleasurable. And the other thing is that it seems a lot, if people have unwilling partners for external condom use, the internal condom can be used by many women effectively in situations where otherwise they wouldn't have any sexually transmitted infection protection. And if you're motivated to get yourself that protection, you can become quite adept at using these. They are used quite widely among sex workers and do decrease exposure to sexually transmitted infections in those populations. I'm not saying they're not used widely in other populations, but I have to say that in the patient populations I've cared for, a lot of people have balked at using these because their first try was so disastrous. It's just a lot to manage all the different how loose this is and getting it in place. It takes some practice. Thanks for your attention with this PowerPoint. Have a good day.